Hello, everybody. Welcome to the latest webinar from the European Social Survey, City St George's, University of London, and National Centre for Social Research. My name is Eric Harrison. I'm Deputy Director of the European Social Survey. So today we have two colleagues, Joanna and Nina from NHS England, talking about patient experience surveys. Before I hand over to them, just to say that you can leave a question in the Q&A function at any time during the webinar, and we will get to them in the question session at the end. So if you'd like to do that, the Q&A function is at the top of your screen because we're in Teams today rather than Zoom. So if you'd like to use that function, please do at any time. And as I say, our speakers will talk for in the region of about 40 minutes, and then I'll take as many questions as possible before the session ends. So without further ado, over to our speakers. Joanna.
Well, thank you so much, and thank you everyone for joining. So we'll just start with a bit of an introduction. So hi, I'm Joanna Barry. I work in the Insight and Voice team at NHS England, and I'm here with Nina. I'll just let her introduce herself.
Hi everyone, I'm Nina Makojnik and I work in the same team as Joanna at NHS England.
And just to briefly tell you a bit about our team, so we are basically responsible for all things related to listening to people and communities. So this includes national surveys, which we'll be talking about today, but also qualitative research, complaints and participation as well. Today we'll be focusing on sort of sharing an overview of our official Statistic patient experience surveys, through which we invite around 2.8 million patients each year to feedback on their care. So we'll be talking about how they're designed, some of the challenges that we face on the surveys, and some experiments that we've run over the years to try and tackle those challenges as well. And just to sort of provide context for the rest of the presentation, I'll just begin with a couple of background slides on the surveys that are delivered by our team. So we currently deliver 4 national surveys, which all collect data on patient experience, and the data collections are all England-based, so they're not UK-wide. All of the surveys, with the exception of the diabetes survey, have been running for a number of years, and they're carried out each year, so on an annual basis. I'll just briefly run through sort of each of the surveys and sort of who we sample and what they ask about. So starting with the GP patient survey, which you may hear us refer to as GPPS throughout this presentation, so sorry in advance for all of the acronyms, but GPPS uses a national sampling frame and invites people aged 16 and over who are registered with a GP to share feedback on their experiences of general practice, pharmacy and NHS dentistry services as well. For the National Diabetes Experience Survey, this is a new survey which was first published last year in 2024. This also uses a national sampling frame, quite similar to GPPS actually, and we invited people aged 18 and over with type 1 or type 2 diabetes to feedback on their care and self-management as well. And then we also run 2 cancer surveys within our team. So the National Cancer Patient Experience Survey collects feedback on experiences of care across the cancer pathway. For this one, we get the sample locally from each NHS trust, and I'll talk about that a bit more later on. But we invite people who are aged 16 and over with a cancer diagnosis who have had treatment at that trust and been discharged during our sampling months. So for this survey, it's April to June of each year. And then finally, the under 16 cancer patient experience survey is similar in that it collects feedback across that cancer pathway, and we also sample this one locally, but we invite people aged 16 and under with a cancer diagnosis who have had treatment and been discharged throughout that year, just to try and increase that sample size. When sort of thinking about the uses of our survey and how they're designed, there are 3 key things that we keep in mind. So Firstly, all of our surveys publish both national and local results. So, for example, we provide data for individual GP practices or individual NHS trusts. And the benefit of this is that it allows these organisations to benchmark themselves, sort of compare experiences over time and monitor improvements locally through using the survey data. The second thing that we aim to do is provide representative data and enough data to support understanding of inequalities. So this includes by demographics, but also sort of inequalities looking at different types of health information, so long-term conditions or type of cancer, for example. And then the third thing is that sort of balancing the need to maintain a relevant questionnaire, we also know that maintaining a robust trend series is really important to the users of our data. We are focusing on the national surveys today, but I just wanted to quickly highlight some other sources of patient experience data which our team are responsible for, just as a bit of context. So the Friends and Family Test is something that we're responsible in our team, and this is essentially a local feedback tool. So it supports local quality improvement. And the idea of this is that anyone should be able to use this to share feedback on their care. It should be quick and easy to do, and there is a lot of flexibility in how that's delivered locally by different providers. We do publish monthly data for this, but it's not a representative survey in the same way that the other national surveys we run would be considered. The data, because of the local variation in how it's delivered, isn't sort of comparable across organisations or considered to provide like a robust trend series. We've also got a qualitative strand of work in our team. So this includes running qualitative research pieces, but it's also quite focused on analysis of the free text data that we collect through our national surveys. So for the 2 cancer surveys that we deliver, they both include open questions, and using the responses from those questions, we produce sort of 2 key outputs for users. So we will often do a national thematic report for each of the surveys, and then we also produce individual free text workbooks for providers. So in these workbooks, we basically categorise the comments to support people with sort of engaging and interpreting the data. Within our team, something that we've called the qualitative data categorization tool has recently been developed. So this uses a machine learning model to categorize that patient feedback into a framework. And the framework was developed by our team from looking through manually sort of thousands of patient feedback comments. And if you want to know any more about that tool or how it works, we'd be happy to put you in touch with that part of our team. So just moving back onto the surveys, I won't go through this in loads of detail, but just wanted to provide an overview of the methods that we currently use on each of the surveys that we deliver. So you'll see here they all use a push-to-web methodology to sort of varying strengths with regards to when the paper questionnaire is and isn't included. But for all of our surveys, people have the option to take part online or on paper. And can also contact the helpline to take part over the phone if that's their preference. For our 2 surveys which use a national sampling frame, so GPPS and the diabetes survey, we've got really good coverage of mobile number in those sampling frames, and text messages are used in those contact strategies as well. So they include a unique link to the online survey for people to take part. And Nina will talk a bit later on about some experiments that have been run on GPPS using text messages and e-letters as well, so she can talk a bit more about that. For the 2 surveys which sample locally, so the National Cancer Experience Survey and the Under 16 survey, The coverage of mobile number there and the quality of it is a bit more variable because that is provided locally. We are keeping that sort of under review and it is improving. And for the National Cancer Patient Experience Survey this year, we will be testing the use of text messages, which Nina will talk about a bit later on in the presentation. And then just for this final slide on background, I wanted to sort of set the scene for some of the challenges that we're facing on our survey, which I'm sure anyone else who runs a survey will be familiar with. But these are things that we just keep in mind when we are sort of designing experiments and thinking about improvements that we can make to the surveys that we run. So firstly, response rates just continue to decline across all of our NHS surveys as they are elsewhere in the sector. But for us, this results in wider confidence intervals and sort of being unable to report on some of the subgroups or lower level reporting that we would want to do, such as providing results for each GP practice. With those declining response rates, we often need to invite more people each year to take part so that we can achieve the number of responses that we want to. But alongside that, postage costs are increasing. So overall, the cost of running a push to web survey is sort of being driven up. We are seeing increasing sort of availability and acceptance of digital contact, and we've tested quite a few experiments in this area to encourage online completion to try and overcome those particular two challenges, which we'll talk about more in the next section. We also experience non-response across our surveys, so lower response rates from certain groups, including younger people, ethnic minorities, and those living in deprived areas. And we see sort of significant variation in response rate by organisations as well. And then we also know there's a real demand for sort of more real-time feedback from data users. And there's just that challenge around sort of balancing expectations for real-time feedback with the time that's needed to produce this sort of high-quality national survey. So I'll hand over to Nina now to just talk about some experiments.
Thanks, Joanna. So I'll now cover some of the innovation across our surveys that aims to kind of tackle some of the challenges that Joanna just talked about. So if we go on to the next slide, starting off with the response rates to our surveys. So as Joanna mentioned, response rates for our surveys have continued to decline over the years, as you can see on this chart. And we know that this is the case for other surveys too across the sector. So we do continually try to review our survey methodologies against good practice in survey design. And we also try to test new approaches as and where we can, with the intention of identifying ways of increasing response rates and or increasing the proportion of people taking part online, as that helps us to reduce the printing and postage costs. So if we go into the next slide, I'll talk about some of the things that we've been testing and implementing. So this slide focuses on some of the testing we've been doing on the GP patient survey mailing strategy. So as a GP patient survey is so large, we're lucky enough to be able to do quite a lot of testing with subsections of the total sample, whilst not affecting kind of the main sample, and the main survey can run as it normally does. So in 2022, we tested what's called a sequential push to web methodology. And then in 2023, we did some further testing with this methodology as a base, and then testing additional elements on top of it, such as an e-letter reminder. And these experiments showed us that implementing this methodology, combining it with the e-letter, would lead to a large increase in online participation without having a negative impact on our response rates or on non-response bias. So we did actually implement this strategy for the 2024 survey. So just to kind of go through the detail of the approaches, our previous approach was what we call the simultaneous push to web strategy. So each participant received 3 paper mailings, and all of these had a paper questionnaire enclosed. And then each mailing was followed by a text message reminder. Whereas our current approach is a sequential push to web. We still send out a first paper mailing, but it doesn't include a paper questionnaire anymore. And then instead of the second paper mailing, we actually send an e-letter via text message. And then only in the third mailing, that's when they still get a paper letter and a paper questionnaire enclosed. And all 3 mailings are still followed by a text message reminder. So implementing this methodology has allowed us to significantly reduce the amount of printing and postage that we do, as we're printing a lot less paper questionnaires, but also mailings by removing that middle mailing and replacing it with an e-letter. And it has led to quite a large increase in online participation. So Joanna, if you could go to the next slide, we'll have a look at the online uptake. So this chart shows the proportion of people responding online to the GP patient survey over the last few years. And as you can see, the change that we made in 2024 led to quite a significant uplift. So in 2023, 45% of our participants were taking part online, whereas that's gone up to over 80% in 2024, which is quite a big jump. And I did also want to mention, as you can see on the chart, there have been some other quite big increases over time. So there was quite a jump between 2019 to 2020. And this is when we made the option of taking part online more prominent on the invitation letters, and it indicated that it's cheaper for the NHS if people take part online. So that saw quite a big jump in people wanting to take part online. And then between 2020 and 2021, we also made quite a big change. So we used to send a paper postcard reminder after the first and the last mailings. But in 2021, we replaced the postcard reminder with text messages, and then we also included a text message reminder after the second mailing. And as Joanna mentioned before, these text messages have a personalised link which people can just click into and take part in the survey, so it's a lot easier for people to take part online. And then if we move to the next slide, I'll talk through some of the other experiments we've recently done, which focus a bit less on the mailing strategy but look at the materials themselves. So the aim of these experiments was to try and increase the credibility of our survey and to encourage people to take part and therefore increase our response rates. So we tested adding an NHS logo to the envelope, which saw a minimal improvement to the response rate. We also tested switching from white to brown envelopes, as we know that brown envelopes are currently cheaper, so we can make a little bit of a cost saving there. And we also know that official letters tend to be sent in brown envelopes, so that can help with credibility a little bit. And that also saw just a slight positive impact on response rates. And then the last thing we tested was the actual content of our invitation letters. So we included a box and some icons to highlight the online login details to make it easier for people to know how to take part online. We also added the name of the local authority to the letter to make it feel more connected to people's local area and more personalised. And we also just generally reviewed the wording against best practice to make sure that everything's as clear and as easy to kind of follow as possible. And we didn't actually see much of an impact based on the letter content, but all of these changes have now been implemented to the GP patient survey materials. So despite having minimal improvements, we've still gone ahead with all of these. And then if we move on to the next slide, I'll now talk about an experiment from a different survey. So this is from the National Diabetes Experience Survey. So in the 2024 survey, which happened for the first time last year, we tested some targeted conditional incentives. So we targeted them at certain groups, and conditional means that people had to actually take part in the survey before they could claim their incentive. So we offered a £5 conditional incentive in the form of a voucher to ethnic minority groups, people aged under 30, and those living in the most deprived areas. And the experiment was tested on a subsection of the main sample. So again, we didn't do this across the whole sample. We just tested it with smaller groups. So then if we move on to the next slide, I can show you some of the findings. So as you can see in the table on the left there, we did find that the incentives increased response rates for all the groups that we targeted, which is positive. We saw the biggest impact for the aged under 30 groups, but we did see an increase across all groups, which was great. We reviewed the survey responses of the intervention groups that had the incentive versus the control groups which didn't have the incentives, and we didn't see any impact on how questions were answered. So all of these responses were able to be included in our results. And we also saw that those in the intervention groups, so those who had the incentive, were more likely to take part in the survey online and also earlier in the process, which again is positive because we know that online responses give us better data quality, and also the earlier we get people taking part, the cheaper it is, as we're having to send out less contacts. However, saying all of this and the positive results that we saw, there are some challenges that we do need to consider when thinking about incentives for our NHS surveys. So as Joanna kind of talked you through the size of all the surveys before, they are quite large scale. So if we were to implement incentives, even if targeted, across the whole sample for our surveys, this could be quite costly. And that could then raise questions on whether that's an appropriate way of spending NHS money. And despite the increases in response rates, we also know that offering incentives that doesn't solve the root cause of why certain groups are less likely to respond to surveys in the first place. So that is just something we still need to be taking into account and thinking about. And then moving on to the next slide, thinking about things that we're looking to test and explore in the near future. So the first thing is transferring the learning from kind of all the experiments and testing that I've just talked about across to other surveys. So for example, the materials which we tested on the GP patient survey the changes are now being implemented across our other surveys. We're also looking at exploring the possibility of utilising the NHS app and the NHS Notify service to contact survey participants in these ways. We're also testing replacing the last paper mailing with an e-letter, as that's something we haven't tested yet, so we don't quite know what the impact of that could be. And we are testing the possibility of sending reminders via email, as again, that's something we don't currently do on any of our surveys. And then lastly, we're also exploring the potential uses of a recontact panel, as we do have a recontact question in some of our surveys. So we get a panel of people who are kind of willing to be recontacted about future research related to their experiences. So we're doing a bit more work understanding the best uses of this. And then just to finish off on the last slide, I did want to look at a bit more detail on one of the experiments we're hoping to hold in the near future, which Joanna mentioned before. So on the National Cancer Patient Experience Survey, we're hoping that if we've got sufficient sample, we'll be able to test a push-to-web methodology, which is quite similar to what we do on the GP patient survey, but with a targeted strategy for those who are over 75. And this is to test whether or not having a paper questionnaire in the first mailing is important for that group and whether that has any impact on the response rates for that group. So the current approach for the cancer survey is a letter with a questionnaire included in the first mailing, a letter on its own in the second mailing, and then a letter and a questionnaire again for the third mailing. And currently, this survey doesn't have any text message reminders. Whereas for the pilot, we're hoping to split it into two groups, where the first group, all of the group, including both kind of under and over 75s, would receive just a letter for the first and second mailing, and then a letter and a questionnaire in the last mailing, and all three of those being followed by a text message reminder. Whereas the second group will include a boost of only those who are over 75, so those older age groups, and they will receive a letter and a questionnaire in the first mailing, whereas the rest of the approach will be the same as group one. So they just get the extra questionnaire in the first letter, and that should hopefully help us understand whether a paper questionnaire is required for this cohort and the older patients, and whether not having the questionnaire would have a negative impact on response rates for this group. I'll hand back over to Joanna now, who will cover some sampling in more detail.
Fab, thank you. So I'm going to talk a bit now about the sampling frames that we use on our surveys, and just sort of run through some of the key benefits that we have from basically having access to these sampling frames to run the survey. So there are two main ways in which we obtain the sampling sort of database or frame for our survey. So we can either do this nationally, for example, on GPPS and diabetes, we use the Personal Demographic Service, which is a database of all NHS patients in England, or we do the sampling locally. So for the two cancer surveys, providers such as NHS Trusts will create a sample of their patients and then submit these to our survey supplier, where they get combined and deduplicated and cleaned to create that national sample. When we have NHS number included, it's also possible for us to link different sources to create a sampling frame. So for example, on the diabetes survey, we linked the Personal Demographic Service, which provided contact details for participants, with the National Diabetes Audit, which identified people living with diabetes and included demographic and health information. But either of these approaches basically provides us with quite a significant amount of information in the sample, which can then be used to deliver the survey. So this includes demographic and health information, information about services such as the GP where the patient's registered or the NHS trust that they had treatment at, and we have name and contact details as well. So this includes address, mobile number and email. I did briefly mention this earlier, but just something to bear in mind is that coverage of those digital contact details does differ across the sampling frame. So just as an example, for the GPPS sample, around 92% have a mobile number, whereas for the National Cancer Patient Experience Survey, it varies by sort of trust to trust, but overall we've got about 85% of coverage there. So I'll just talk now a bit about some of the key benefits to our surveys that we have from using these sampling frames. So where we've got that national sampling frame that can be used, we can easily incorporate boosting into our sample design. So for example, on GPPS, we know that there's quite significant variation in response rate across GP practices. And so practices with a lower response rate can be oversampled with a sort of cap applied to that to aim to achieve the required number of responses at practice level. We can also ensure that we do random probability sampling with stratification by key variables that are in that sampling frame. So, for example, by age, gender, or ethnicity. We don't currently boost any demographic groups in our sampling approach. We have considered this for some surveys, but when we've looked into it, the analysis has shown that we do have enough data for most subgroup analysis already without that boosting, and we would need to quite significantly oversample to alter how that works, which could be not very cost effective or sort of practically possible in some cases. The information that we've got in the sampling frame also has quite a few benefits for how we design the method and the materials as well. So, for example, we can personalise the survey invites so they go to the named individual that's been sampled, and we can include other personalisation as well, such as place of treatment or local authority. And we know this helps with legitimising the survey materials, but there is a balance between sort of achieving this and making sure that people don't feel over-targeted by any personalisation that's included there. There are information governance considerations as well around what's disclosed through the text message personalisation in particular. I guess just bearing in mind that that can pop up on people's phones or sort of be opened by anyone more easily than a letter. We can also use different modes of contact and targeted contact strategies as well because of all the information that we have. So Nina mentioned some of these, like the targeted incentives experiment for diabetes and the sort of under and over 75 age groups that we are testing on the cancer survey. We are quite interested in this sort of targeted survey design area, and it's something we've been thinking about more as a team to try and find ways to minimise that non-response that we're seeing between different groups. And the sampling frame also benefits how we report on the data at the end. So it's possible for us to provide results which are linked and attributed to local organisations. So for example, NHS Trust or ICB, and this supports use of the data for quality improvement. And then using NHS number, it's also possible to link the survey data with other sources, such as data on clinical outcomes for further analysis. One of the other principles that we wanted to briefly talk about is patient-focused design. So this is something that we incorporate into each of our surveys to just try and ensure that people with lived experience are involved in that design process. We do this throughout the survey life cycle, but some of the key questions that we tend to explore are sort of why do people want to take part in an NHS survey and what are the barriers to them doing this? What should we include in the questionnaire? So balancing what's important and relevant to patients to be able to feed back on with what's useful and relevant to users of the data as well. How can we design materials to motivate people to take part in the survey? So thinking about how we can make it easy to take part or legitimise the contacts that we're sending to them. And then how can we communicate the results effectively as well? We currently achieve this through sort of qualitative research, working with lived experience partners, so on our survey advisory groups and through other regular engagement as well, through cognitive testing and through running some follow-up surveys as well, which I'll show an example of on the next slide. But we're always keen to do more here. For example, as a team, we're looking into the respondent-centred design framework and sort of what we can do to align there where possible. So just to provide an example of what we know about why people take part in our surveys, this shows the results from a follow-up survey that was included at the end of the National Diabetes Experience Survey for people who took part online. So just a caveat that it's only collecting data from those who took part in the survey itself and then also answered these optional follow-up questions. But the results do really resonate with what we know from other research, which is that the key motivation for people taking part in a patient experience survey like this is wanting to help the NHS. And from other engagement we've done, we often hear that having really clear messaging on how people's feedback will be used to help the NHS and improve care is really important to include on our materials. And then just linked to having that patient-centred design, we try to have a really strong focus on inclusivity and accessibility across our surveys. So this includes working with the Plain English campaign to review our questionnaire and materials for some of our surveys. So they're an independent company that supports the use of simple communication in documents. We provide information about the survey in Easy Read. We provide translations of the questionnaire in other languages and in BSL as well. We ensure that the online survey design is accessible, so for example, compatible with screen readers, and that you have the option to do things like increase font size. We also provide a helpline that people can contact for any questions or support or to take part over the phone. And then finally, we provide large print formats and braille formats of the questionnaire on request as well.
Thanks, Joanna. So I'll now talk a little bit about the sensitive data that we collect and kind of the measures and mitigation we have in place to reassure survey participants. So if you go to the next slide, Joanna. There we go. So it's because our surveys are healthcare related, we do handle quite a lot of sensitive patient data at various stages of our surveys. So over the next few slides, I'll talk about some of the key stages of the process. So sampling and contacting patients, when we're actually collecting the data, and then when we're processing the data for reporting. So if we go into the next slide, I'll talk about sampling and contacting patients first. So when we're actually reaching out to patients and kind of selecting who is taking part in our surveys, we handle quite a lot of bits of data. So this can include identifiable information, so people's names, addresses, telephone numbers, NHS numbers, and so on. And we have this information so that we can actually contact people and reach out to them. We sometimes handle confidential health information, so information about people's diagnosis or treatment details and so on. And then we also handle some demographic data, which can include special characteristics such as age, ethnicity, and so on. So at this stage, we have various measures in place to make sure that the data is being handled in the appropriate ways and it's being handled securely. So first of all of our surveys have a legal basis, which allows us to contact individuals without their consent, and we make sure that we're really clear about this and explain what the legal basis is. We're transparent around where we got people's information from, so where we got someone's name and address from, and we're clear about how this information is being used and stored. So we have FAQs on our survey websites. We include this detail on our invitation letters, and we also have the privacy notice on the NHS England website, which also explain all of this. We store and transfer all of the data securely, and we also give everyone the option to opt out of the survey if they don't wish to take part and they don't want us to contact them anymore. And then if we move on to the next slide, when it actually comes to collecting the data, so we'll actually send the surveys out and ask people to take part. At this stage, we're handling different data, so we're actually asking people to give us answers to the questionnaire, so it's self-reported information. that we're looking at here, and this could be health information, it could be people's demographics. And then in some of our surveys, we do also have some free text comment boxes where people can write in kind of whatever they wish to write in to answer the question. And we know that this could include identifiable information. So at this point, the measures that we have in place, first of all, we make sure to make it really clear that taking part is voluntary. So people don't have to take part at all if they don't want to, or if there are certain questions that people don't want to answer, questions can be skipped, so we don't force people into answering any of the questions. We're also really transparent about how patients' data will be processed and used, so that people know exactly how the data will be used at the time that they're deciding whether they want to take part or not. And we know that providing this information is really, really important in ensuring their trust. So it's essential that we cognitively test any wording about data protection that we include in our letters or on our websites to ensure that it is actually understood by patients and that it provides the reassurances that they need, so that they do want to take part and data protection is not a barrier. And we also reassure patients that nobody who cares for them, so the nurse or the GP, for example, will know what they have said as an individual. And this is really important so that we can reduce bias in survey responses, as we don't want people to think that if they say something negative, that could have a negative impact on their care or their treatment. And then moving on to the last slide in this section, which is about when we actually come to process the survey data that we receive back from patients. So the data that we're handling here is the same data which I was talking about before. So it's the data that we receive back from patients from filling out our surveys. So we've got the self-reported information and the free text comments. And again, at this stage, we have lots of measures in place. So we do publish our data, so it is publicly available on our websites. However, we only publish aggregated results, and we apply suppressions to all of the results too. And any free text comments that are in published outputs are anonymised. So all of these measures make sure that an individual can't be identified in the outputs that we publish. We do hold record level data from the surveys, but we don't publish this data. We don't share it with local providers, apart from the free text comments. We do sometimes share record level data with approved organisations and researchers, but this is done on a case-by-case basis where people have to apply for this data. We review the agreements with information governance teams to make sure that the data that's being passed on is being used in appropriate ways. But I think that's everything on this section. And then just the last bit of this presentation, I'll talk a little bit about the impact of our surveys, so who uses the results and how they are used. So if we go on to the next slide, I'll cover kind of the outputs that we produce first. So we produce a really wide range of outputs, as we do have a really wide variety of stakeholders, so we want to make sure that the outputs that we publish suit everyone's needs where possible. So the types of outputs we produce include infographics, slide packs, so these outputs are a lot more visual, but then we do also publish data tables for those who just want to see the data kind of row by row for each organisation or at national level or whatever level they want to look at. We also have analysis tools available where you can kind of look at any question that you want from the survey and apply filters or kind of do cross-tabulations of various questions in the surveys. Like I mentioned, we have the record level data on request, and then we also have some qualitative comment workbooks for the surveys that do have free text boxes, and we also produce national thematic reports, again, where we do collect any qualitative data. And then moving on to the next slide. In terms of who uses the data and how the data is used, like I said, we've got a very wide range of stakeholders. Our surveys cover different topics, so it's kind of sector-wide interest in them. But we know that national policymakers use the data, so this could be NHS England, or the Department of Health and Social Care. We know the data is used widely by local providers and commissioners, so this could be NHS Trust, ICBs, GP practices, and so on. We know the public might have an interest in the data, so this could be patients or the families and carers. And then also there's kind of other organisations and other users, so this could include think tanks, so organisations like King's Fund, Nuffield, and so on. Charities, so there are some specific, for example, Macmillan or Teenage Cancer Trust and Cancer Research UK all have a big interest in the cancer surveys that we run, but then also other charities like Age UK, for example, are always interested in the data. And then we also get a lot of interest from academics who use it, kind of review the data anyway, but also use the data for their own further research. And then also regulators such as the CQC use the data. And then on the right-hand side, there's a list of kind of uses that we're aware of. So I won't go through all of these in detail, but this can include the data being used as an evidence base for policy making, national and local improvement programs, things like outcome frameworks and indicators, monitoring progress, like I said, academic research, but then just in more general ways as well, identifying inequalities for different patient groups, and yeah, just generally understanding patient experience with the aim to being able to improve experience where possible. And then I think the next slide should be the last slide. So we did just want to focus in on a more specific use of our survey data. So what we call the Cancer Experience of Care Improvement Collaborative is a collaborative which encourages people, providers, to work with patients to understand what lies behind their responses to the 2 cancer surveys that we run. So the collaborative was launched by the NHS Cancer Programme back in 2019, and it was done as a way to encourage providers to work with patients to understand what lies behind their survey results. And the collaborative brings together groups of both staff and people with lived experience from different organisations to work in a structured way to improve services. And the aim is for each project team to use insights such as the survey results, but also wider, to try and understand the experience and then do something about it to improve it. So far, there have been 6 cohorts of this collaborative, which equals a total of 87 teams. And all of these have been focused on improving experience of cancer care. And each cohort focuses on a slightly different topic. So, for example, cohort 5 focused on pre-existing health conditions. So we had mental health, dementia, learning disabilities, and autism focused on in that cohort. And then cohort 6, which is the latest cohort, is focusing on administration of care, which has been highlighted as a key driver of patient experience in the National Cancer Patient Experience Survey. But I think that's all the slides. So yes, so I think we're going to take some questions now if there's anything in the chat, but if you'd like to discuss anything further, as we're really aware we've covered a lot of different areas at speed, so probably not been able to give as much detail as you might like on some of the topics. So if you want to discuss any further, if you've got any questions, you can get in touch with our team on the email on the screen. But also if you've got any learnings that you could share with us on the challenges that we're facing, then we'd be really, really open and really keen to hear from you as well. So yeah, please do get in touch if you can.
Thank you so much to both of you. I found that extremely interesting. It was nice to have a change from sort of nationally representative sort of general surveys to looking at particular specific populations of interest. So that was all very interesting. There are a few questions, and I've got a couple of ones of my own as well. Let's start with an internal question from your colleague Amy, who works at NHS England. It's basically, cut a long story short, says, work in a regional team where we've discussed the value of having a regional dashboard on patient experience work, which combines high-level data with intelligence from the kinds of surveys you've talked about. To your knowledge, do you have any experience of this having been implemented anywhere in the country or nationally?
Yeah, so thank you, Amy. Nationally, this is something that our team are hoping to look into this year, and that would probably involve engagement with regional teams as part of that sort of exploration to see what already exists out there. But yeah, at the moment, that hasn't been implemented by our team nationally.
Thank you. Andrew Phelps makes an observation, not a question, but points out that ONS did some research in 2017 that showed online responses were higher for brown envelopes as against white envelopes on the transformed labour force survey. It kind of makes intuitive sense to me. I think I'd be likely to open Open a brown one. Lindsay MacDonald asks, do you publish results from this experimental work around survey methods that you've talked about today?
So we don't publish the results from our experiments, but we do get once we complete the experiments, we do write them up, kind of collect our findings and put them into a report. So if there is something of specific interest, do reach out and we can kind of share more detail. But yeah, we don't tend to publish them just because they are quite long, complex, with a lot of information that probably a lot of people don't need. But yeah, more than happy to share anything if there's something of interest.
Okay, so ask people to reach out directly after the talk. Stefania says, you mentioned you sometimes share anonymized record level data. Is there a specific procedure in place to gain said access?
Yes, so again, if you reach out to our team, we can help with that. But basically, there's a form that would need filling out. We're more than happy to have a discussion before you fill the form out to try and understand if kind of your use is likely to get approved, so you're not wasting time filling out forms. But yeah, there's a form that then goes through kind of review on our side, and then if approved, the data's shared securely.
Okay, and a question that I think I can answer is from Public Health Wales. Could the slides and video be shared, please? So all our talks will end up on our YouTube channel, so you'll be able to watch the talk as many times as you like in the future. Okay, while I'm still waiting for a few more to pop up in the Q&A function, there's a couple of things that occurred to me. Not least your what I would describe as a wow chart very early on, where you showed how proportion of people choosing to take it online had bopped up all the way to 80%. And this was a double wow for me, because it kind of, in my own mind, I was assuming that the demographic profile of people with these types of morbidities was older than average. So I was assuming, for instance, type 2 and cancer, I was assuming that that on average your population was already on the older side, which would tend to be sort of negatively associated with online participation. So I wondered if you got any extra info on that.
I suppose Nina can come in on the GPPS element, but I guess just as context, it does differ from survey to survey. So something like the National Cancer Patient Experience Survey definitely has a much older profile in the population, and that has a much lower proportion of people taking part online, though it's somewhat combined with the method because we don't use text message reminders on the cancer survey currently, whereas the GP patient survey is anyone age 16 and over registered with a GP. So it's a bit more of a spread that is similar to the general population. I'm not sure about diabetes. I think that's a mix, because the type 1 population was in there as well,
Okay.
which was younger. But yeah, it's definitely an effect that we see dependent on age.
Thank you. I've got another question about envelopes. Do we know if the increased response rate for brown envelopes was analysed across areas of deprivation? The reasoning being, for some people, a brown envelope is a bill, and they'll happily put it to one side and try not to open it. Any information on that?
So I haven't got the report in front of me to know exactly what we looked at. However, for all of our experiments, we do, when we get the results and we look at the experiment group versus the control group, one of the things we do look at are the different demographics to understand whether there is a difference in who's responding and how they're responding. I imagine IMD would have been one of the things we looked at, but I can double check that. And any of the kind of things we've implemented would have not had a negative impact on the groups we looked at. So there shouldn't be, but yeah, I can double check the detail of that for Matt.
I guess the other element is it would be a brown envelope, but with an NHS logo still on it. So there's still that element of someone knowing that it's a letter from the NHS.
And just a question from me, because it's in the same kind of area, coming back to IMD areas. So I was wondering, given the fact that you'd done some experiments targeting areas of multiple deprivation, I wondered in the general sample design, given the fact that, well, all the associations between deprivation and poor health, I wondered, do you did you sort of stratify at all by the IMD sort of scores in the sample, or is it just a free-for-all national coverage?
So we would stratify for those which have a national sampling frame, so like GPPS and diabetes, because we have access to postcode. But it's sometimes a bit complex because we were often sampling within like provider. So we would want to ensure there's enough within a GP practice or an ICB, and then you sort by sort of demographics on top of that as well. But for the local surveys, so the cancer ones, it's more of a census of the sampling months because that sampling is done locally. And we need to try and minimise the burden on sort of trust providing that to us, as well as like the complexity of it. But yeah.
Okay, super, thank you. Deborah wants to know, she's interested in the qualitative data categorization tool. Is there someone you can contact about it?
Yes, definitely. Me and Nina are not involved in that, but it's super interesting. So I don't know if the chat is working, but our email address is on the slides that will be sent around. So if you contact that, you'll get put in touch with the right person in our team.
Lovely. Follow up from Matt, I think. Have we done any testing around the online link put in text messages? The link shown in the text image didn't look like it was from an official NHS source, and a lot of people are fearful of scam messages.
Yeah, so that's a great question, Matt. So we do testing of our materials overall, where obviously the link would have been included in the text messages. It hasn't really previously come up too much, but in the recent year we've had on the GP patient survey, we have had some feedback from patients saying they're unsure about the link. It looks a little bit like a scam. They don't want to click it. So we are looking into this in further detail for next year to see what we can do to make it look a bit more credible. But then there are also some restrictions around kind of what we can put in text messages. Before working on this project, I never knew kind of all the difference between HTTPS links and other links and kind of the restrictions around what you can and can't put in a text message and what that can look like. So yeah, we're looking into that for next year as we've had some similar feedback from patients.
And I just guess for the meantime, there's some other things we do to try and legitimise the text. So like having a sender name that references the NHS or says something like NHS survey. And we tend to reference the letter as well. So the text would say something like, we sent you a letter last week, like now please click this link. So it's like linking it back to the different contacts as a way to try and legitimise that text. But it's coming up a lot on the cancer survey as well recently about the format of that URL. Don't know if the prevalence of scams is increasing and it's got people thinking about it more.
Thank you. A question from Karen. Are you going to look at expectation bias and its links to index for multiple deprivation, i.e. if people have higher expectations, open brackets, from wealthy areas, do they score lower than those from poorer areas?
So as far as I'm aware, I don't think it's something we've looked at before. Certainly something, so we can look at all of our results by IMD, so we can kind of compare results from wealthy areas to those from more deprived areas. But I guess what we probably want to do to answer that question is follow up with some qualitative research potentially, because what we won't have in our survey information is, if there is a difference in scores, we wouldn't know whether that's due to expectations or due to something else. So I guess that's something for us to think about.
Yeah, it's a whole problem with sort of measures of job satisfaction as well, isn't it? It's difficult to disentangle the various drivers. Yeah. Okay.
I think there was, it's not for IMD, but I think there was a piece done around ethnicity on this using GPPS findings to look at sort of expectations versus experience and how that was feeding into the data. I think it was done by Cambridge University, but we can try and dig that out, send it around if that's of interest.
And we have another. Claire says, oh, please do you have the link to where we'll find the video and the slides? Yeah, it'll be on the talk will be on our YouTube channel, but Stefan will reach out and let people know where materials can be located. Okay, so it looks as though we've exhausted quite a long set of questions. Thank you very much for addressing all those. We worked you quite hard. But I think we'll draw the session to a close now. So thank you to our speakers once again for a very interesting talk. I learnt a lot this morning, and I hope the rest of you did as well. Thanks to everyone who attended. Please keep your eyes on our socials for details of our next webinar. But for the time being, from everybody at ESS, it's thank you and good afternoon.